And thank you, Martin, also for your introductory talk and setting me up as a non-CBT therapist or non-psychologist to talk about CBT. So I am definitely in that scientist camp as someone who's not delivered CBT, but likes to think about it and likes to talk about it. And actually, in thinking about CBT, and I'm going to cover in 20-ish minutes, I will try to keep to time, is what we mean by CBT, where it's come from, why CBT for tinnitus. I'll briefly cover some treatments and components, talk about some of the evidence base that we've been involved in analysing, briefly mention guidelines and recommendations, and then finish with a very brief overview of a project that we've published recently, which is around increasing access to CBT for people who have tinnitus. So CBT, what is it? I think that there are a lot of recent histories and a lot of work by psychologists in the 50s and 60s regarding CBT, but actually there are a lot of much earlier references and credits given to cognitive and behavioural approaches to therapy. And this is one quote I really like, which I discovered recently, which is that men are disturbed not by things, but by the way which they take, the view that they take of them. And this came from a manual. It's actually a short manual of Stoic ethical advice. It was produced by a philosopher called Ariane, who is a 2nd century disciple of this Greek philosopher here, Epictetus. And this is a manual developed nearly 2,000 years ago, which shows the way to achieve mental freedom and happiness in all circumstance, which to me is really something of an essence of CBT. If we take definitions, the APA definition, so the American Psychological Association, describes it as a psychosocial intervention that aims to improve mental health. So it's got a focus on challenging and changing cognitive disorders or distortions and behaviors, improving emotional regulation, and developing personal coping strategies. So it is a talking therapy. It's about challenging those unhelpful thoughts and helping people to learn and modify their own thinking patterns, change their behaviors, and ultimately improve the way that they feel. And some of the kind of defining characteristics, I think, of CBT, got separated from other psychological interventions and counselling, is that it's very structured and there's a definite educational component to it. There's a lot of emphasis on work that happens both within and outside of therapy sessions. So of practice and homework, and it's very collaborative. So I like to think of CBT as something that's more contractual between the therapist and the patient. So the therapist will work with the patient, but there is an expectation for active participation on both sides and a commitment towards and seeing a positive outcome. CBT is very goal orientated. So again, the therapist works with the patient to define some specific goals that will address or represent a resolution to some existing problems. And it's time-based. So whereas counseling may not have a finite window to it, programs of CBT are typically in the literature between 6 and 14 sessions. So it's not something that's continuous, it's a set program, and during that time the patient is expected and challenged and should work towards developing and honing skills and techniques that they can use beyond that window, beyond that program of CBT, essentially to become their own therapist and to manage their condition. So why CBT for tinnitus? Well, as we know, and as we've seen in the previous talk, lots of issues and lots of problems arise because of tinnitus. And a lot of these are functional, so it has an effect on listening, it has an effect on sleep. And actually here is a list of 21 themes. And these are themes of problems that we identified from a very large clinical data set where over 700 people were asked a very simple question within their clinical interview, why is tinnitus a problem? And these are the kind of things that emerged. And as you can see in there, there are lots of psychosocial, there's lots of emotional issues in there. And just a few to highlight, I guess. There's lots of loss, so there is grief within the experience of tinnitus, loss of sense of self, loss of peace, loss of control. there is a huge amount of fear. In fact, fear was one of the most common themes that emerged from this particular study. So that's fear of what tinnitus is, what it means for me, fear of an ability maybe in the future to cope with it. I'm okay now, but actually I have an intense fear that in however much time or later on in my life, I will just be completely unable to cope with it. And again, if we ask our clinicians, and this is just a similar study, but asking clinicians what it is that they think makes for a successful outcome from clinical intervention for tinnitus. What emerges really strongly here is, again, the education, so that need to demystify, address fears, misunderstandings, engagement, so the patient needs to be on board, engaged and an active participant in the treatment. And overall, again, reiterating, as Martin pointed out, empowerment. So actually empowering and equipping the patient to go beyond their treatment, their course of treatment, to continue to live well with tinnitus. And so this is all lends itself to psychological intervention. And also that understanding of these problems lends itself to having psychological models of tinnitus and those attempts to actually explain how and why some people have tinnitus of a particular perceptual characteristic, a particular loudness, a particular pitch, and on top of that, they have this disorder. They have a severe negative impact of the tinnitus on their quality of life. And yet someone who has a very similar tinnitus or an identical tinnitus in psychoacoustic terms, who is completely not suffering from it, and it is not having any impact. So what is it that separates those two? And actually, what is it that will help the person who suffers from a particular tinnitus to move into that group of individuals, and that much larger group of individuals who have tinnitus, who experience tinnitus but aren't bothered by it? So these psychological models then can underpin rationale and the development, of course, of new cognitive behavioral interventions. And there are many models, again, as referred to previously, the fear avoidance model, whereby an individual has a source of tinnitus, so there's some physical, neurological source leading to a perception. And for the majority of individuals, this can be assessed as a benign signal, and this allows people to continue as normal, and they're in a recovery state. However, for some individuals, there will be a misinterpretation, so that fear will creep in. I'm not quite sure what this is, and tinnitus-related fear develops because they misunderstand, and sometimes that misunderstanding can be quite catastrophic in terms of the fears that it generates. This then leads to task interference, avoidance of social situations, avoidance of particular activities that were very important to the individual previously. And this culminates in disability, that's social withdrawal, anxiety, depression. And of course, this then is self-perpetuating and self-fulfilling. So the opportunity then with cognitive intervention is to try and move the individual from being in this to being in this. And there are a number of elements here that might be targeted in terms of treatment. Another model I'll just mention here is the cognitive behavioural model, and this is one that we're very familiar with here in the UK. So this is a model from Lawrence McKenna that puts negative automatic thoughts here right at the centre. So again, you have the acknowledgement of tinnitus as a neuronal activity leading to the detection of a tinnitus sound, and these negative automatic thoughts. So these are thoughts that emerge in the moment, that emerge in particular situations. But if over time, these lead to safety behaviors, which are reciprocal in terms of negative automatic thoughts. They enforce and reinforce erroneous beliefs, which reinforce negative automatic thoughts. And then this cycle. So this leads to increased arousal and distress, selective attention and monitoring. So people start to actually check into their tinnitus and tune into their tinnitus, think about how bad it is. How bad is it today? How bad is it in this situation? Is this somewhere I need not to be coming again? Is this somewhere I need to be avoiding? And so, of course, this then cycles, as with the other model. This increases tinnitus detection, which will feed again into the different arms of the model. And we also have in here distorted perception. So this selective attention, this monitoring is here associated with this distorted perception. And I'm sure many of you will have heard many individuals talk about that tinnitus being the loudness of a jet engine, which is kind of 140 decibels, whereas actually in the vast majority of cases when we try and loudness match tinnitus, it's more in the region of a 10 to 20 decibels. And we've done some empirical work actually to try and validate this model here. And I'll just refer you to the Hanscom et al. Paper in Ear and Hearing last year. And particularly emerging within that were these issues of selective attention and distorted perception most strongly driving overall tinnitus stress. I've also got reference here to psychology tools, which provides a more patient-friendly version of this if you're interested in using it within consultations. So in terms of treatments then, CBT for tinnitus, we're talking about here behavioural therapies, which are about helping the patient to overrule learned associations between their tinnitus and counterproductive responses, such as those safety behaviours. Cognitive therapies, which focus on that relationship between thoughts and emotions, identifying and changing the errors in thought processes, and then combinations. So combining elements of behavioral and cognitive theories so that overall within a treatment program, you're addressing these dysfunctional thought processes, the behaviors and the emotional responses. I'm not going to cover them all today, but we did publish a scoping review quite early on in doing the work that I'll be presenting later, looking at actually what components of therapy have been used or applied in tinnitus or prescribed for tinnitus. And in fact, did the scoping review a few years ago now, identified 138 different potential components that could be grouped together in any number of ways to form a treatment. So some I'll just mention as slightly more prominent include this guided discovery, where the therapist puts themselves into the patient's shoes, tries to see things from their viewpoint, and through that process broaden their thinking. Exposure therapy is very commonly observed within treatment programs. So this is about exposing patients to the trigger, so to their tinnitus, in order to reduce the response. So within the kind of protective environment of a therapy session, actually exposing them or assigning them a task or an activity that exposes them to their tinnitus. And over the course of that hour of activity, where they are actively listening to their tinnitus, they learn that actually it's not threatening, it's not emotionally crippling within that time. And so through learning within that protected time, that should and hopefully will generalize to their everyday environments, where they can learn again to be within certain situations and doing certain activities with the knowledge that actually they can exist with their tinnitus and it's not catastrophizing. Cognitive restructuring, again, this is about finding and altering those irrational thoughts. And there are various approaches that are used to that. So cognitive restructuring being a whole collection. I'll just mention another model here. This is a very basic CBT model, but is a helpful way of kind of working through a scenario. So the A here is the activating event being the tinnitus, and then beliefs and consequences that follow on from that. So the beliefs here may be, for example, that tinnitus just never goes away. It only ever gets worse. And the consequence of that for the individual over time is anxiety and increased avoidance of activities. So the D here in the model end is dispute. So this is an opportunity through various means to work with the patient to identify scenarios or realities that actually would dispute those beliefs. So actually getting them to a place of their truth, which is, I can do something about it to make it better. I can put myself in situations and do activities that will make it better. And sometimes tinnitus is better than others. I do have good days as well as bad days, and that needs to be reflected on. And actually putting those disputes in place and in mind allows for a reevaluation of the effects. And here we would hope then to see a lessening of anxiety and more activity and return to those hobbies and socializing. Some other common tools I'll just leave you to read. I think activity scheduling, looking at best, worst, and most likely case scenarios, journaling, behavioural experiments, role play. So really putting the patient face to face with their actual reality and challenging those negative thoughts or potentially irrational beliefs. Just in terms of research evidence then, I'll just mention the Cochrane review. We've published a very extensive Cochrane review on CBT for tinnitus last year. 28 studies, nearly 3,000 participants, all with tinnitus for 3 months or longer. Duration of tinnitus here ranged from 3 to 22 weeks, and of course, with varying number of sessions, mostly conducted in hospital, and most of these trials related to CBT delivered by clinical psychologists. Just one of the meta-analyses from that. So here we have favored CBT versus favored waitlist control. So this is a comparison of a course of CBT, and we've grouped all formats of CBT that were suitable really for pooling in a meta-analysis into this single figure here. And so what you can see quite nicely, I think, is everything on the side of CBT compared to waiting list control. So that's a positive overall finding. And in fact, the bottom line is an effect size of this 0.56, which is a moderate clinical effect. And that's specific to the negative impact that tinnitus has on quality of life. So we also saw some small but additional benefits in reducing symptoms of depression. Very little evidence of adverse effects. But what we are certainly lacking in the literature is evidence for longer term effects. So are these effects, these acute effects of CBT treatment, are they maintained in the much longer term? And just a caveat very briefly that, of course, CBT is not going to be effective for everybody. The therapist does need to be good and needs to be able and to encourage the individual to develop those new replacement thoughts. Many patients are not going to be ready to do the work and to actually commit to doing that practice and to doing that homework outside of their sessions, which is so critical. There may be wider issues outside of what's shared within therapy sessions, or family issues, for example, that are really outside the reach of what CBT will do for those individuals. And of course, there may be many individuals for whom CBT is just not going to be effective. So they're, for examples here, those with significant intellectual disability are very young children. Just very briefly then, I think I'm on my 5-minute warning. So in terms of clinical guidelines, so 2 years ago now, we published the European Tinnitus Guideline, and within that, there is a strong recommendation for CBT on the basis of the evidence that we identified through systematic review and then subsequent clinical trials. There's also within that guideline, for those interested, a recommended pathway for individuals who experience tinnitus through ENT and audiology, where they can receive education and management of hearing loss, through to tinnitus specialist services for those with more severe tinnitus. Further psychological assessment and then evaluation is either requiring a less intense psychoeducation or more intense program of CBT. Also just mention here NICE guidelines. So this is a UK-centric guideline on tinnitus assessment and management. And here again, the recommendation is in favour of CBT, but across the board, quite specified to be delivered by psychologists in that lack of evidence from trials involving clinicians other than psychologists in delivering CBT. And on the back of that, the #1 research recommendation within this NICE guideline is that we look at the clinical and cost effectiveness of CBT delivered by healthcare professionals other than psychologists. And in this guideline, they're specifying audiologists as an example. And so then just finally, this is a project that we have started to address that particular question. This is the Tin-Man study. Again, this was published last year, and it involved the development of a treatment manual to be used by trained audiologists to provide psychological support for tinnitus. We followed that up then with a feasibility trial. It's a highly collaborative effort, 3 stages involving the scoping review I've already mentioned, a Delphi study, where we worked with patients and clinicians to identify what they considered should be included. We then took that information and structured it into a treatment manual. There are some examples of the things that patients were keen on having in and out, and clinicians were keen on having in and out of the manual. Theoretical underpinning was, again, the cognitive model of tinnitus and other common principles. And essentially what we ended up with here was a book, and this is something I'm happy to share. We published the feasibility trial last year in IJA with just a brief summary of the manual. If anybody is interested in receiving the manual, I'm happy to provide it to you. So this provides essential elements of psychological intervention that can be delivered by audiologists in terms of patient assessment, providing a rationale, goal setting, patient education, and then modules, optional modules on patient management that are really determined according to the outcome of the assessment. And importantly, it includes a section here on relapse prevention. It also comes with a complete toolkit of questionnaires and worksheets, etc., that complement different elements of the manual. As I said, it went through a feasibility trial, a very small feasibility trial, just 30 patients across 3 sites, and this was to test whether it was ready for a clinical trial or not. And the bottom line here is that it was very acceptable to patients. They found out it was effective in reassuring them about their tinnitus. However, the audiologists that were delivering this intervention felt that they focused and they reached their competence in delivering psychoeducation according to the manual. And we just need a little bit more work to get them over that threshold to actually use techniques such as thought challenging and graded exposure in a more therapeutic context. So that's where I'll finish, and thank you for your attention. There's just a brief summary of the talk that I've just run through, but in the interest of time, I think we can move on to our Q&A, and thank you. Just acknowledge my funders there, email address, and a link to our departmental website.